Good afternoon, everyone. As Sharon said, I'm going to describe to you two models. Lots of models have been mentioned today, and the two I would like to just give you a little bit more detail about are Money Follows the Person demonstration and the COCT model, which stands for Care for People with Dementia in Their Environments. Next slide, please. So starting off with CMS's Money Follows the Person, or MFP rebalancing demonstration. This demonstration has been operating since 2008, and over that time, 46 states and the District of Columbia have participated, as well as a related tribal initiative in some states. And the principal aim is to support state efforts to rebalance their long-term services and support system. We heard some about rebalancing in the last session. So this is one of the mechanisms that's been put in place to try to do that in order to provide choice of where to live and where to receive services that people need. And another aim is to eliminate barriers in both state law, so we talked about regulation, statute, state Medicaid plans, and also state budgets that can restrict use of Medicaid funds to allow people to get care where they want. It also aims to strengthen the ability of Medicaid programs to provide home and community-based services to people specifically who choose to transition out of institutions. And so since 2008 up through the end of 2020, states have transitioned over 107,000 people to community living through this program. And that website there can just take you to CMS's website about MFP if you want more information. Next slide, please. Eligibility for MFP is pretty straightforward. You have to want to move out of an institution. It's a voluntary program, have been there for at least 90 days, be eligible for Medicaid, and it's open to people of all ages and all disabilities. So that includes people with dementia and many other neurodegenerative conditions. Next slide, please. And so the transition planning starts with a referral, and that can come from literally any source. It can come from a resident themselves, their families, nursing home staff, and a transition team is put together that includes those groups that I was just mentioning, as well as regional transition coordinators, community program care managers, housing coordinators, and others depending on the individual situation, with the goal of developing and then executing or putting in place a community-based person-centered LTSS plan that the person will then receive care through in the community. Next slide, please. And so I've been involved with evaluating the Connecticut Money Follows the Person program. It's one of the larger and more active ones, and it's been operating since 2009. So I just wanted to give you a kind of a quick overview of who transitions through this program, what do people look like who are moving out of institutions. They're varied. About under half are older adults, and we have about 40% with a physical disability under age 65, and then smaller groups of people with mental health or developmental disabilities. Other states have different proportions, but even though almost half are older than 65, the age range is from ages 1 to 104, and it's diverse. 25% non-white race, and another 11% are Hispanic, and we have about 13% with a dementia diagnosis. That's certainly an undercount of people who have cognitive impairment, but that's just a specific diagnosis. Next slide, please. Thank you. In the Connecticut MFP evaluation, we follow people for 2 years after they transition and have found really positive outcomes. And these are mirrored in the national evaluation data as well that Mathematica has up on that CMS website. You can find links to the national evaluation. Lots of measures of quality of life and consistently showing improved after transition and sustained over that 2-year period. Quality of life measures, general life satisfaction. Relatively few returns to institutionalization, although there's certainly movement in and out and in and out. And in Connecticut, we also have a caregiver survey that we do with Money Follows the Person participant caregivers, family members, and we see really low levels of caregiver burden, lower than what's typical in a community sample of caregivers, which can be attributed largely through these caregivers getting support through this program, having a paid care plan in place that then supplements the work that they're doing. And this ties in nicely with the previous session, so I just wanted to emphasize that. But of course, there are areas for improvement, both at the individual level. So we see a slightly increased rate of falls among people back in the community, and frequent ED and hospital visits as well. And then certainly areas for improvement on the system level. Multiple people have referenced this really severe HCBS workforce shortages we're facing right now. And MFP has been implemented in a pretty varied way across the different states because it is a Medicaid program. There's a lot of variation, and some of them are very small and quite siloed programs. So there's definitely opportunity to expand and develop stronger programs. The transition process itself can be very slow. It can take months or even years for some people if they're persistent. And there's definitely a need for a more proactive identification process of who might be eligible, who might benefit, who might be interested. So I'll move now to the COPE program. So if we can go to the next slide. Oh, wait. One more slide about MFP, maybe the most important slide. We at UConn do a quarterly report to the state Medicaid program, which is where MFP is housed here. And the last page of every quarterly report is a success story. It's an interview with a person who has transitioned. And so you can just take a quick look at a small sample of the over 7,000 people that have transitioned in Connecticut. Lots of people, lots of different backgrounds, and a lot of positive experiences. So it's always, I think, helpful and important to put a face on the data. Thanks. Okay, next slide. And now turning to the COPE program. So this is a program that was found efficacious in a randomized controlled trial with community-based participants. It was developed by Laura Gitlin and Kathy Pearsall, and includes an occupational therapist component. It's really an occupational therapy driven intervention where they complete up to 10 home visits over 16 weeks, although that can vary. And they develop prescriptions or action plans in company with the caregivers. It's a dyadic intervention with caregivers and people that they're caring for with dementia. Those action plans are aimed to address specific target program areas for that specific diet and that caregiver. And it does also include a nurse practitioner component who does one in-home visit and assesses dehydration, pain, and other symptoms, and collects some lab tests, and then conducts a follow-up call with the caregiver to go over the lab results and arrange to how the best to share results with primary care physician. Next slide, please. And so that efficacious program was then tested by my colleague here at UConn, Rick Fortinsky, in the COCT translational study, which was an NIA-funded study. The COCT study tested both the effectiveness and implementation of COPE in a real-world setting using a publicly funded, Medicaid-funded home and community-based services program for older adults. Recruitment into that, and it was a clinical trial. Design. And recruitment was done in collaboration with a care management organization. In this existing program, there are no services before COPE, there were no services to help family caregivers improve their dementia management skills. But about a third of the approximately 16,000 clients in that program have dementia. So it was just a ripe space for testing this program out and trying to bring it from that evidence-based kind of clinical, randomized clinical trial controlled setting to operationalizing it in let me just tell you, it is not a controlled setting in this community-based program. And with this here, we did see really positive outcomes, both for caregivers, people with dementia, and system costs. Next slide, please. So give you just a couple of pictures here of beneficial findings. You can see between baseline and end of intervention, the level of difficulty managing the target problem areas was vastly improved. And next slide. And target problem resolution at the end of the intervention, as reported by the caregivers, about 22% were eliminated and another 75% reduced. There are lots of other outcomes, but just zipping through these couple things here to give you a flavor. Next slide, please. And so next steps for COPE. In the last session, we talked about scaling up. So in order to scale up COPE, it's really important to streamline Medicare and Medicaid coverage. Both OT and RN services are billable. under those programs, but maybe a bundled payment is needed for the ancillary pieces of the program, covering training, program materials, ongoing coaching. So it may be something that's relevant for Medicare Advantage or ACOs, something like that. In terms of equity, we've spoken about the materials at this point are only available in English. So that's the next step that's really important, and is also needed to develop a network of trained providers and develop systematic referral mechanisms. Okay, thank you. Next slide has references. You can read more about both programs, and the next slide shows some websites where you can find more reports and my contact information. Thank you.